Thank you. Okay, it's a nice, it's a pleasure to talk about prenatal and perinatal cardiology with you. And this topic comes from, as you know, it was very recently the first case of prenatal valvuloplasty in Israel. It was 3 or 4 months ago. It was an aortic stenosis. It was in Hadassah in Karem, and it was performed by Professor under the control of Professor Azaria Rein in Hadassah. And so we spoke a lot in every team of perinatal cardiology and obstetrics about this opportunity and this new way of treatment of congenital heart disease, prenatal congenital heart disease. And it seemed interesting to see what is the experience of Laurent FERMONT and Damien Bonnet in Necker, and to see what we can do and where we are with this prenatal valvuloplasty so far, not only in Israel, not only in France, but elsewhere. And why to treat about prenatally those babies with aortic stenosis? You know that there are 2 types of management of aortic of those cases. The postnatal management may lead to univentricular surgery or palliations, and biventricular treatments, and with possible recovery or preservation of 2 adequate ventricles by valvuloplasty or surgery. Second, prenatally, the indications must be adequate, and this is very at the center of this talk. For the mother, the maneuver must be absolutely safe. And for the fetus, it must be life-saving or protect, recover endomyocardial function. As you know, and it's published so far, the risk for the fetus are high. We'll see that. And now you see very recently a paper, an overall paper, meta-analysis showed that the fetal death for aortic valve valvuloplasty is more than 35% of cases. To relieve obstacles to preserve or restore biventricular function, and this is very important, we start from the major paper of Jagel and his colleagues about the development and the relationships between hemodynamics and anatomy prenatally, and the possible evolution of those cases. And so it's after the development of the techniques, it should be interesting to interfere with this impact of the hemodynamics on anatomy, and to interfere with the natural history of those cases. And finally, the obstacles must be isolated, and this is crucial. It must be isolated at the valvular levels, excluding extensive lesions shown and associated lesions or fibroelastosis. The first case of prenatal valvuloplasty is now from 25 years. It's Tynan and his colleagues in London with Lindsay Allen. It was in 1991, and you see it's 25 years. And in 25 years, we're still in the learning curve, and in learning curve to determine the real indications of those maneuvers. 25 years, and we are still in the learning curve. Why? One reason is that the strictly isolated aortic stenosis is rarely done prenatally at an appropriate gestational age. To perform those valvuloplasty, it's absolutely necessary to be before the age of 23-25 weeks of gestational age. And as you see that, and it's a recent paper from 2015 from Boston, as you see, it's about 10% of appropriate cases to be managed by valvuloplasty. 10 cases are diagnosed prenatally at the appropriate age. And this is a major event to beat in this learning curve. The high risk for the fetus is confirmed recently by Moongrady. Moongrady is the group of Stanford, and this very high risk of maneuvers is confirmed in this group. I wish to remind you that we are speaking about aortic stenosis, and about aortic stenosis is la loi de Laplace. Laplace is a very major physicist, as you know that, and this statue is coming from Beaumont-en-Auge near Deauville. We all know it's very famous in France, Deauville, especially in the Jewish community. And Laplace is coming from Beaumont-en-Auge, and he makes this major advance of mechanics of fluids, the relationship between pressures, tension, and the radius of the cavity. But as you know, it's there are two ways to appear for left ventricle. In coarctation of the aorta, you know that there is a small ventricle. Small ventricle, why? Because the problem is stemming from the admission of the blood. Its admission is the foramen ovale, it's the ductus arteriosus, it's left superior vena cava. What you want is the admission. On the contrary, in the aortic stenosis, the problem is from the ejection. The ejection at the aortic level, so you have an evolution of the ventricles during this malach, this evolution, and you have for the normal to the hypertrophy and the diminutive cavity of the left ventricle, and afterward, loi de Laplace, the dilatation, hypokinesia, and hypertrophy of this ventricle. So it's another way to appear for the left ventricle. Coarctation is small ventricle, aortic stenosis is hypertrophy, and after that it's dilatation and thin wall, and problem of the walls. So, this is neonatal treatments. This is the first case from 1996. You can see the prenatal aspect of this left ventricle. It's with aortic stenosis, with the jet, with the fibers of the papillary muscles, and at birth you have this aspect of dilatation of the left ventricle. You can see, and after the valvuloplasty, postnatal valvuloplasty, you have a recovery of the left ventricle, and 6 months later you have a normal left ventricle. This this young man now is followed in Hôpital Necker by Professor Bonnet, and I have recent news, and it's normal. Another time, you see the left ventricle, very amazing, and you can see that there is a possible recovery, even postnatally, of those ventricles. And this will be discussed about this. When are we able to do this prenatal dilatation because of those evolutions, postnatal evolution of left ventricle And why to do prenatally if we can get postnatally by valvuloplasty or surgery the same improvement? You see on the other part of the, where is it? You see on the other part that from this publication from Boston, you have from postnatal evolution, from prenatal dilatation here, and after postnatal treatment, you have the recovery of these ventricles. So the why to do prenatal valvuloplasty is to first to avoid this evolution from left ventricle to hypoplastic left heart. Now it's well established that it's possible to, from a dilated ventricle, to make an evolution to hypoplastic left heart. The second is to avoid this evolution, and from aortic stenosis you have here to cardiac insufficiency with major involvement, major impact on the mitral valve, and to avoid those evolution from aortic stenosis, it may be interesting to develop valvuloplasty prenatally. And third, it's necessary not to act too late, because if we miss in this development of la loi de Laplace law, you can get this aspect of the left ventricle with major dilatation of the left ventricle, thin aspect of the parietal walls and septal walls, and it's it's too late to get a recovery. The appropriate time is that probably. It's exactly the case. It's not the case of Azaria Rhine, but it's exactly that case. I saw with him the imaging, and it was like that. You had a dilatation, hypertrophy, dilatation, but hypertrophy, appropriate wall of the muscles, not endocardial fibroelastosis, and significant mitral insufficiency. And probably this case are able to be dilated to avoid evolution to severity and very severity of aortic stenosis. So when it's a difficult case, a difficult discussion, not too early, that you can see the aortic stenosis with dilatation of the ascending aorta and bicuspid valve here, and you see that the ventricle is coping with this obstacle, but it was a significant aortic stenosis. This baby has been operated at 3 weeks with a very quick evolution of the gradient between the left ventricle and the aorta, and we know that within days, it's possible to have this evolution, quick evolution. But it's a mistake to dilate prenatally in those cases. Not too early equally. You can see an hypertrophy with appropriate ventricle, but there is a jet in the aorta, there is a mitral insufficiency, there is a high pressures in the left ventricle calculated from the mitral valve. So it's this fetus is dealing with this obstacle, and it's not an appropriate time to make the dilatation. It was treated postnatally at 4 days. And we saw not necessary to do too early, but it's important not to wait and to miss the appropriate time. You can see here this case from Necker Hospital with huge dilatation of the ventricles, retrograde flow in the aorta, and the aortic stenosis. You can see the aortic annulus. It's an appropriate case for dilatation, and probably it should have been done earlier. It will the appropriate time. And now, now, you see the new papers, very recent. All those papers are very recent, and they focus on the natural history of those cases to be able to determine the appropriate moment. This is a paper from Gardiner, multicentric paper from Gardiner, discussed in a paper from Boston. And you can see the measurements which are important, but you can see an overlapping of the measurements. For individual case, from the measurements, it's very difficult to be sure that we are. So it's a monitoring that lead to determine the appropriate moment of this maneuver, and we have to be to begin this monitoring very early, and you saw that it's a problem to get from the obstetricians the diagnosis as soon as possible, and to follow the stenosis at the valvular level, the fibrosis or hydrops or ductus venosus, the foramen ovale, the thickness of the walls, the pulsatility of the AV levels, the velocity of the mitral insufficiency, and the direction velocity of the aortic flow. This is very important to manage. And you have here pulmonary atresia with intact septum, which has been dilated prenatally in Paris. And you can see an appropriate right ventricle. It's not the small right ventricle of the pulmonary atresia. And you can see before the dilatation, this is important, the inflow of the AV valve. You can see a continuous flow at the AV valve. And we made this, from this indication to the dilatation, and we made this indication from the possible perspective of involution of the right ventricle from this absence of inflow at the AV valve. And after the dilatation, you can see that there is a recovery of anterograde flow at the AV valve, and you can see the efficiency of this dilatation from the AV valve. And now this child is following in Necker and is doing well with the biventricular ventricle. This case, you can see places of endocardial fibroelastosis, aortic stenosis, and retrograde flow at the aortic level after the truncus arteriocephalic artery, and it was followed. It was chose to be an appropriate time to make this dilatation. And you can see the recovery of this case from the left ventricle from pre-valvuloplasty, and you can see the recovery of the left ventricle after the dilatation. There is a decrease of the diameter of the ventricle and recovery of the muscle function. So it's an appropriate, it's a real possibility to do that, and each case must be discussed very closely, not to be in excess or not to miss the appropriate this. And those are the recent experience of Necker. Laurent Salomon, after, if you want to comment, no problem, for sure. And we focus on the aortic stenosis in this talk. You can see that 33 dilatation of the aorta recently, and 25 valvuloplasty. And on in 25 valvuloplasty, only 13 are born alive, with 6 termination of pregnancy and cases that lead to be in fact a diagnosis of failure of the dilatation or hypoplastic left heart. You can see that it's dangerous, and it's necessary to bear that in mind when you decide to make this maneuver prenatally. It's dangerous for the fetus, with 50% in a case of problems, a major problem in this experience. And there are 50% of univentricular repair and 50% of biventricular repair. And I would end this talk by these 2 sentences from recent papers. From a paper from Jan Marek and his group in Great Ormond Street in London, you can see that he writes, "We still can't reliably identify patients born with critical obstructive left heart lesions and a borderline left ventricle who would benefit from biventricular repair long term. The presence of endocardial with left ventricle diastolic function appears to be a more important risk factor than volume or dimension of the left ventricle." This is important for our efforts to make those measurements prenatally. There is not a close correlation between the measurements prenatally and the fate of the fetuses. And identification of endocardial fibroelastosis remains challenging and can be underestimated. This first paper, second paper of conclusion, prenatal valvuloplasty. And you can see that the group of Stanford writes, "Furthermore, there are no data to support the efficacy of fetal cardiac intervention and no data to show that it's safer than expectant management. We remain unable to ascertain whether fetal cardiac interventions provide better, similar, or poorer outcomes that can do cardiac procedures performed only after birth." In conclusion, it's really important and necessary to get this technique in our hands for the future. But it's very important, even after 25 years, to bear in mind that we are still in the learning curve. Thank you very much.